Bismillahirrahmanirrahim. Dr. Asim. In the previous lectures, we have discussed about different endocrine glands. Today, we will discuss about the adrenal gland. And in adrenal gland, there are a lot of diseases which are common, but today's topic is the Cushing syndrome. So, first of all, I would like to briefly highlight the learning objectives of the lecture. First of all, we'll go through the adrenal pituitary hypothalamus axis, how it works, what are the basic components of it, and some concepts about the adrenal diseases which are common in our society. Then pathophysiology of Cushing syndrome with particular reference to its diagnosis and its clinical presentation. Then what diagnostic tests are used for its workup or for its diagnosis. Then what are the clinical significance of each lab test for the diagnosis of Cushing syndrome? So just to recall you the anatomy and the physiology of the adrenal gland, it's located above the kidney, composed of the adrenal medulla and cortex. And then if we further see it, that there are three zones over here, which are zona glomerulosa, then fasciculata, and zona reticularis, and then there is adrenal medulla. You see over here that the more component is of the zona fasciculata, which is covering this part of the cross section. If we see this, what are the different main hormones which are secreted by the different components of adrenal cortex? Like glomerulosa, that secretes aldosterone, and fasciculata, that secretes cortisol, and reticularis, that secretes the sex hormones androgens, and medulla secretes epinephrine and norepinephrine. These are the different hormones secreted by the adrenal cortex and the medulla. The adrenal cortex, first of all, zona glomerulosa secretes mineralocorticoids in which the aldosterone is the predominant hormone which is secreted, and it has mineralocorticoid activity. The glucocorticoid, the cortisol, by cells in the zona fasciculata, they are secreted, which are involved in the Cushing syndrome, and then sex hormones, testosterone and estradiol by zona reticularis. Same catecholamines like epinephrine and norepinephrine by chromaffin cells in the adrenal medulla. There are some key terms which you must keep in your mind. Corticotrophin releasing hormone, that is abbreviated as CRH. Then adrenocorticotropic hormone ACTH, which is the main component, and we have to diagnose its production, either it's from the gland or it's from the outside, ectopic. And then Cushing syndrome, which is the nomenclature, and but it is basically hypercortisolism, result of the excessive production of the cortisol either by the adrenal cortex. Then congenital adrenal hyperplasia is also known as the adrenogenital syndrome, and Addison's disease, destruction of the dysfunction of adrenal glands, primary adrenal insufficiency. But we'll focus on this Cushing syndrome in rest of the slides. So whenever there is stress or hypoglycemia, there is in normal physiology and normal metabolic functions. CRH is secreted by the hypothalamus, which acts on the anterior pituitary to release ACTH in sufficient amount to act on the adrenal cortex at zona fasciculata, so that to secrete the cortisol. The cortisol further causes fat and protein breakdown, increases blood glucose level, and it has anti-inflammatory effects. But when it is high, it has a negative feedback on the hypothalamus, which suppresses the secretion of the production of the CRH. So it has the inhibitory effect, and the green which are showing, they are the stimulatory, having the stimulatory effect. This is the normal process and production of the different hormones by the hypothalamus, pituitary, and adrenal cortex. Now, what are the disorders of adrenocortical function? First of all, if we consider hypersecretion and associated clinical disorders, if there is hypersecretion of the cortisol, it will be Cushing syndrome. If it is aldosterone, then it's the primary hyperaldosteronism or Cohen syndrome. Then androgens, then congenital adrenal hyperplasia and adrenocortical carcinoma. These are the clinical disorders, the hormone responsible for these one. If there is hyposecretion due to some causes, there is less secretion of the cortisol and the aldosterone, it will be primary adrenal disorder like Addison's disease or congenital adrenal hyperplasia. Then cortisol and adrenocorticotrophic hormone, adrenal insufficiency, secondary to the pituitary disease. Now, what is Cushing syndrome? Basically, Cushing syndrome is a metabolic disorder caused by the overproduction of cortisol by the adrenal cortex. We have to differentiate its different forms because one is the Cushing syndrome and second is the Cushing disease. You must be clear in your mind that Cushing syndrome is a broader term in which Cushing disease is included, but Cushing disease is particularly specific for the pituitary adenoma, which releases increased amount of the ACTH, which leads to the excess cortisol production by the adrenal cortex. So between the two, we have to differentiate between these two conditions by different tests that we will discuss. Now, the causes of Cushing syndrome, first of all, the most common causes of Cushing syndrome or the increased cortisol level or hypercortisolism are the exogenous or iatrogenic. Iatrogenic means given by the medication or by the healer. These are the exogenous causes and they cover about more than 50-60% of the cases of the hypercortisolism. The prolonged administration of ACTH or glucocorticoids due to these are given like in asthma, like in rheumatoid arthritis, like in autoimmune diseases, and they cause increased level of the cortisol, which have effects on the body similar to the Cushing syndrome. Now, endogenous causes, they are divided into broadly either ACTH dependent or ACTH independent. Meaning by ACTH independent means ACTH is being secreted, but the cortisol level is increased and ACTH is not low. That we will discuss in further slides. Then ACTH dependent, that there are three categories. Number one is the hypothalamic lesion due to the increased CRH production. Second is the pituitary lesion, which is due to microadenoma or macroadenoma. Then ectopic production. Ectopic production means like bronchial carcinoid or small cell carcinoma of lung, then pancreatic carcinoma, neuroblastoma, and Wilms tumor. These are the causes of the ectopic production. Now, Cushing syndrome, exogenous glucocorticoid therapy more common. Second is the ACTH producing pituitary adenoma, which is 70% of the Cushing disease or the Cushing syndrome. It is called Cushing disease. Then glucocorticoid producing adrenal neoplasm, which is irrespective of the ACTH produced by the pituitary or the CRH by the hypothalamus. So this one is important because it is localized to the adrenal gland. Then ectopic production of the ACTH by neoplasm. They account for the 10% of the cases of the Cushing syndrome. Cushing disease is the most common form of the endogenous Cushing disease. I'm not talking Cushing syndrome, I'm saying Cushing disease. It means it is probably and mostly from the pituitary adenoma. It may be microadenoma or the macroadenoma. Caused by a tumor in the pituitary gland that secretes excessive amounts of the ACTH. then it will have effect, which you saw in the picture of the previous slides, that it will have effect of increased production on the adrenal glands. These are benign and common, more common in the women. 70% of all cases of the Cushing syndrome. Then excess ACTH from the pituitary adenoma can induce dermal hyperpigmentation, because then this effect of the ACTH is also on the other parts of the of the adrenal gland, which secretes other hormones, if it is in excess. Ectopic ACTH syndrome. It is the form of the Cushing syndrome in which benign or malignant tumor rising from in places other than the pituitary, leading to excessive release of the ACTH, subsequently cortisol into the bloodstream. It is about the 10 to 15% of the cases of the Cushing syndrome. These are the causes: bronchogenic carcinoma, which I told you, carcinoids of the thymus and the bronchial adenoma, and pancreatic carcinoma. These are the few common causes of these one. If you have to write down what are the different causes of Cushing syndrome, you have to go write all these three major causes of the Cushing syndrome. Then the condition in which symptoms of the Cushing syndrome are brought on by the administration of the synthetic forms of the cortisol, such as prednisone and dexamethasone, used for the different diseases which I told you, like asthma, rheumatoid arthritis, and other inflammatory or autoimmune diseases. It originates from the Greek, literally meaning by coming from the healer. Then there is another term which is used to pseudo-Cushing syndrome, condition in which the alcohol or obesity or some more stressful conditions, they induce symptoms of the Cushing syndrome without the tumor, that leads to the increased cortisol level. Now, what are the clinical features? If we see, it affects almost different parts of the body. For example, there is accumulation of the fat, central obesity is there, moon faces is the key feature, then supraclavicular fat pads and the buffalo hump. When you will see the picture of the patient, you can diagnose in the OPD if the patient having all these symptoms, you can easily diagnose or suspect the case of Cushing syndrome. Then skin is thin because of the effects of the cortisol, then facial plethora, increased redness, and then easy bruising because of the thinning of the skin, and then stria on the abdomen. Then on the muscles, there is wasting, proximal muscles of the extremities. They are wasted, but there is central obesity and atrophy, wasting of the extremities. Osteoporosis and the fractures are common in these patients. Then on CBS, the effects of the cortisol, it may be hypertension, congestive heart failure, hyperlipidemia, and diabetes. That is, these are the known effects of the increased level of the cortisol in the body. Then it can be on the reproductive system, like gonadal dysfunction and menstrual irregularities, which are common in females. Then increased rate of the infection is present over there because of the increased level of the cortisol, which leads to the inflammatory effects of neutrophil or immunity, or they are decreased, and poor wound healing is common in such patients. The psychological disturbances are present over there, like emotional lability and irritability, sleep disturbances. These are present, or which may not be present, depending on the how the patient presents. Now, you see, this is the central obesity, accumulation of the fat around the abdomen, and these are the stria, and this is the easy bruising, and this is the picture of the stria because skin is thin and there is mild deposition of that breakdown of the RBCs, and there is prominent bruising over the and easy bruising. It's if it is touched very easily, it is bruised because skin is very thin. Thinning of the limbs, which I told you, of the extremities. Otherwise, patient is looking very fat, and these are the different pictures of the easy bruising on the back and the different parts of the body. Now, how we'll diagnose a case of Cushing syndrome? Because there are a lot of tests which can be done, but proper test utilization is most important aspect of diagnosis. First of all, there are different types of the cortisol. As we discussed in the thyroid, like D3 is in the free form and is in the bound form. Similarly, cortisol is also in the free form, and this time, and this is the range at 8 a.m. Why it is specified over here? Because there is a one peculiar feature of cortisol, that is its level is high in the morning and its level is low in the evening. So levels at 8 a.m. are different, and if we check the levels at 5 p.m. or 4 p.m., they are definitely less than the morning levels. This is called circadian rhythm. In a patient with this Cushing syndrome or related to these disorders, there is loss of this circadian rhythm when we check the levels at the different times. Then second is the total serum cortisol level, which may be misleading because it will be increased definitely, but it may be borderline, but more important is the free cortisol level, and then total serum cortisol level, which is at 8 a.m. it is 5 to 23, and at 4 p.m. it's 3 to 13 microgram. So you can well appreciate the difference between the levels. Then urinary free cortisol is one of the tests which is used for the diagnosis. Then salivary cortisol level are also very important in the, which most probably reflect the level of the free cortisol. It's not routinely done, but it is documented at some places it is done, which helps in the diagnosis. Here you can also see that at 7 a.m. to 9 a.m. the level are 700 to 750 nanogram, and at 11 midnight it's less than, because as the patient timings are towards the sleeping time, so levels are reduced. How to evaluate? The most important step is the correct diagnosis. Correct diagnosis means we have to take the history. History is the most important component of the diagnosis. First of all, we have to exclude the exogenous administration of the glucocorticoids, taking for some diseases. That includes in the history. Then timing of the cortisol sample, as I told you, is very important at what time we are taking the sample. Then basic screening tests to confirm the hypercortisolism are number one. As I told, it's the most sensitive test, but not routinely performed. The late night salivary cortisol level. If it is increased, it highlights that the patient is having a high cortisol level. Then 24-hour urinary free cortisol again. And then one test is overnight single dose dexamethasone suppression test. In this test, we just give one tablet of dexamethasone and measure the level of the cortisol next day at 8 a.m. If there is suppression, then it can be documented that the patient is not having the Cushing syndrome. If there is no suppression, then we have to find out the cause from where it is increased, which is the basic reason that either it's the adrenal, it's the pituitary, or it's some ectopic form. Now, there are other tests like low dose dexamethasone suppression tests. Suppression means whenever we give some form of the dexamethasone orally, the rationale is that it should suppress, because the level are increased in the normal person, and they should suppress the production of the CRH and ACTH, which ultimately have effect of on the adrenal gland. So this suppression will be there. In this case, if the level remains more than 5 micro, then it is hypercortisolism. It is given for 2 days, 6 hourly, then measured on the third day of the morning at 8 a.m. Then it is 2 days, low dose, 2 milligram, 6 hourly for 2 days. If the suppression is less than 3 microgram, it is in percentage of the microgram suppression. This is not the value. Then it rules out Cushing syndrome. Then comes the overnight 8 milligram. These are the different categories of the test. If we don't find any conclusion by these tests, then we further proceed on the following tests. The baseline sample at 8 a.m. for cortisol is taken. Then 8 milligram dexamethasone is given at 11 p.m. Then take 8 a.m. next morning for the cortisol. Less than 50% baseline value. If the suppression is less than 50%, significant suppression is considered. This is the interpretation of the test. If the diagnosis of Cushing syndrome has been established that the patient is having increased level of the cortisol, then we have to identify either it is because of the ACTH or it is just because of the adrenals. For that, we have to go for the serum ACTH levels. If it is low or undetectable, then it is in ACTH independent cause. More likely, it can be adenoma or some malignancy in the adrenal gland. If high, then Cushing disease or ectopic ACTH syndrome. This is very important to appreciate and interpret that serum ACTH level is the second blood test, which is used for the diagnosis of Cushing syndrome cause. Now we are going to establish the cause. If level of ACTH is less or undetectable, then it means the cause is in the adrenal. If it is high, then the cause is in the pituitary or it is in the ectopic production of the ACTH by some tumors. Now we have to differentiate between these two. Then for that, we go for the high dose dexamethasone suppression test. This high dose dexamethasone 2 milligram, 6 hourly for 2 days, cortisol level measured at 8 a.m. and day 0 and day 2. Then partial suppression of the cortisol more than 50% confirms pituitary, because if we are giving the dexamethasone exogenously, it should ideally suppress that one. If if microadenoma is there, there will be suppression. More than suppression, that will confirm the Cushing disease. Failure to suppress, that's just the ectopic production of the ACTH, and it is maybe due to some tumors, as I told you. So high dose is to differentiate between the Cushing disease and the ectopic production. Then this test, CRH stimulation test, is not routinely done now. 100 microgram of CRH is given, then serum ACTH and the cortisol measured for 2 hours. Then if there is increased level of the ACTH and the cortisol, pituitary Cushing or the Cushing disease. If no response, then ectopic. This is not routinely done, but because in this, there are a lot of requirements for this one. And before that, we proceed to the diagnosis has been made based on the clinical symptoms, based on the different tests like the urinary free cortisol and the serum cortisol and low dose dexamethasone test. Differential diagnosis of Cushing syndrome. If we consider the pituitary tumor, the ACTH will be high. Cortisol level will be high. If it is ectopic, both will be high. For this, we have to differentiate because these blood levels are almost giving the picture. Although in ectopic, the level of the ACTH is relatively more high as compared to the pituitary tumor. Then if it is an adrenal tumor, then ACTH will be low because of the negative feedback. And cortisol will be high because of the autonomous production of the cortisol from the adrenals. Then if there is suspicion of the exogenous cortisol, the ACTH will be suppressed because already but cortisol level will be high. This will have the effect on the hypothalamus and pituitary. So the production of the ACTH will be low. This is for the exogenous cortisol, but for the exogenous prednisone, these will be low. Both will be low. Cortisol production will not be high in exogenous prednisone. If there is adrenal lesion, then urinary free cortisol is high. High dose dexamethasone test not suppressed. ACTH level is low and CRH test is negative. This is not considered so enthusiastically, but these three are considered for the differential diagnosis and the summary of the findings. In pituitary adenoma, if it is microadenoma, the urinary free cortisol and in macroadenoma, both will be high. But this suppression will be present in the microadenoma, but not in the macroadenoma. In both, ACTH level will be high. Maybe in some cases in microadenoma, the level of the ACTH may not be very high, and CRH will be positive in both. If we are considering some ectopic, then urinary free cortisol high, it will not be suppressed because it is produced irrespective of everything. There is no concept that it will be suppressed by the high dose dexamethasone. Then exogenous urinary free cortisol will be low because it is not being produced by the body. It will not be suppressed and the ACTH will be low. This is the differential diagnosis on the basis of the investigations which can be utilized for the proper diagnosis. Then other investigations for the adrenal cause, ultrasound abdomen and CT MRI abdomen, looking for the adrenal adenoma or carcinoma. Then further confirmation of the Cushing disease, CT MRI, no mass seen, then bilateral inferior petrosal blood sampling for ACTH level. It's difficult, but it is the most sensitive test for if we are looking for the pituitary micro or macroadenoma or Cushing disease, but not routinely performed. Then for ectopic, then we have to go for the radiological investigation like chest X-rays, CT chest, abdomen, looking for the small cell carcinoma or bronchial carcinoids or pancreatic carcinoma and Wilms tumor. Now we will discuss some important aspects of the different this topic. I'll just go through the MCQ. A 29 years old female patient present to OPD with rounded face, hirsutism, upper body obesity, easily bruised skin, severe fatigue, muscle weakness and anxiety. She also complained of the irregular periods. So till this we must apply our mind. There may be multiple conditions. As being long-term asthmatic sufferer, she has been prescribed prednisone for the past 2 years. Finding on examination revealed high fasting blood glucose levels and high blood pressure. Serum cortisol levels were below normal. Which one of the following is the most likely explanation to account for the patient's symptoms? Decreased level of the insulin? No logic. Increased level of the testosterone? All these effects cannot be due to the testosterone. Excess exogenous glucocorticoid, that is also because patient is taking. Then increased hepatic metabolism of the steroid hormones. Which can be the best answer? Obviously, history leads to the excess exogenous glucocorticoid hormone administration. So history, clinical features, and levels of the cortisol, they highlight towards the exogenous glucocorticoid hormone administration. Then another, a 45 years old female presents with hirsutism, acne and hyperpigmentation of the skin. After a thorough physical examination, physician notes that she has suffered hypertension, shows signs of the buffalo hump, Now, this word has been used for this in this. It is a clear key feature, key point for you to solve the MCQ. On her back between the shoulders, Cushing syndrome is suspected, which has been already told. Suspected and lab tests show elevated blood cortisol level. All goes towards. Now, question is in other direction. What they are asking for? Which of the following is not the feature of her provisional diagnosis? Hyperglycemia, definitely it will be because cortisol is there. Low blood pressure, you can judge either it leads to the low blood pressure or high blood pressure. Obesity that is present, and then osteoporosis and purplish stria in abdominal skin. So the answer will be low blood pressure. The last one we will discuss, simple question, which of the following is the mechanism causing the Cushing disease? What they are asking for the mechanism causing for Cushing disease. Adrenal diseases, meaning by from the pituitary. Adrenal adenoma, that is not the Cushing disease. Excess secretion of the pituitary, ACTH. Then treatment with the corticoid, this is the exogenous. ACTH production by the carcinoid, then it is ectopic. Then ectopic acid bronchogenic carcinoma. These are not the option. The option will be excess excretion of the pituitary ACTH. Now, by this, you can judge what type of the questions can be there and what are the different tests which will be used for the diagnosis. And you must remember the clinical features and different tests which are used, which I told you, particularly with the reference to the urinary levels of the free cortisol and free cortisol blood in the blood, and moreover the ACTH level. These are the three main important tests which are done, and moreover you have to differentiate by the high dose or low dose dexamethasone test. Thank you very much.